both shared our passion for flying, and so I couldn't get about finding this old photo of mine, which is from '98, like you can see in the corner. So basically, I started with flying when I was just in med school, okay? So it has been a passion ever since, and what I want to approach, as I said, an OR is very close to a cockpit environment. So we have something what we call the flight crew concept, and I think we could all learn a lot about from the longly established security panels and checks and counter checks we have in aviation to avoid, in a very dense workload environment, errors. And these are not medical errors. These are human communication errors, misinterpretations, relying on each other in the wrong way and in the wrong moment. So this flight crew concept is something which we can apply very good to a surgical OR. So what is it? The flight crew concept consists on checklists and consists of the control and check on communication. It has to do with staffing, with work pressure and pace, with teamwork, with recurrent staff training. Even like pilots have to have recurrent training every X years. And organizational learning. That means you have to learn from the errors you make. And error management, how you respond to the mistakes you make. We all make mistakes. We all have complications. You can ignore them and say, I don't have any complications, or you can learn from them and not doing them again, or have less probability to do them again. And you need to give leadership support for the people who work with you, a very important thing, and sometimes it lacks in this kind of support. We had an interview from Jim before in checklist. This is a World Health Organization checklist. There are many different ones. You can adapt them to your special surgery and to the way of how you think what adapts the best, but they're very useful. In our clinic, we have them implemented in the data system. That means they're digitally, and in the program, you can't go over the steps. Basically, you can't start to codify the anesthesia and everything in the patient until the checklists are filled out and clicked. So you have to go through them before you can further advance with the rest to start the operation. There's a handoff card. You need to know a little bit from the further information from the patient, which you had from the pre-op, from the exams, from the nurses on the floor, and this can be very nicely organized over handout cards, which are kind of checklist, which are based on how you pass information. So information passing is very, very important. So there's a nice article on this, the role of checklists and human factors for improved patient safety in plastic surgery, which I recommend everybody to read on. It was in PRS. Communication. Something which surgeons are very often not good in, because what we understand under communication is shouting to a nurse, give me something. It's a one-way communication. But communication in general is bilaterally. It flows in both directions. So it's communication about patient information, it's communication about procedure information, it's a communication between surgeons, if there's several, between nurses and surgeons, and with patient relatives. So all these factors of communications are paramount to have a safe environment when you perform surgery. What is a handoff? We had this handoff. It's a transfer of information along with a transfer of authority and responsibility. And we have this in many, many stages when we treat a patient. When the patient comes from the ward into the OR, gets prepared, prepped, when it's passed to anesthesia, when basically after the operation we need to pass it to medium care unit or intensive care unit. So all these moments, which are kind of interfaces, are moments where information can get lost and where little errors can go into the workflow. And most catastrophic outcomes in anything, in aviation, in medicine, in surgery, is not one single error, it's a chain of errors. So we should try to exclude this chain of errors. This is an example about how you can basically control communication and check communication up. So you basically tick off of what kind of patient information has been transferred and what kind of treatments have been done and what kind of checks have been performed to see that we fulfilled all the needs on information on this patient. And then a communication, to be a real communication, needs to be open. That means when you hear something you're not d'accord with, you need to stop the line, and you may have to make an assertive statement. You have to get attention, you have to speak up, express concern, state the problem, and propose a solution. If you don't follow those steps, if you just bend your head and says, it's my boss, I won't say anything, I know it's wrong, but I won't say, this is a moment where troubles begin. And we have to understand, surgical teams are teams. It's not one single surgeon which is minions, okay? So this is very important. Staffing is important. You cannot run a safe environment if you don't have enough staff. Why do many surgical centers do not have enough staff? Because it's the most expensive component in the whole thing. So staffing is important. Having good staff, recurrent trained staff is important, and having enough nurses and helps to have a good control of your patient before and after the surgery is paramount. As I say, as Jim said, if you just do per hazard your rounds the next day and the patient is almost dead, and because there was not enough staff to check on him regularly before, it's a flaw in the system. It's system immanent. And when you have system immanent built-in errors, they will occur sooner or later. So have an eye on staffing, very important. Then there's workload and pace. They're factors affecting our vigilance. Human vigilance is limited. It's limited to time. When you do the 5th breast augmentation in a row in a day, you won't be as vigilant as in the first one. This is clear. When you operate 7, 8 hours in a row, you're not clear anymore. So you have to limit your own limits, the limits of your team, and the limits what the whole structure can do as well in a workload. Okay? Fatigue, environmental conditions. The design of the task, if you give somebody a task which is boring, a task which is very repetitive, he will at the moment they give him not think about it anymore. He will just make a click, but he will not really perform the task. He will just make an automatic assumption that anything is right. So psychological conditions in every work design are very important. And competing demands, the anesthetist asks the nurse one thing, the surgeon asks the nurse another thing, should be as well completely discussed and avoided, because it creates a void of responsibility and of competing demands. Sleep loss and fatigue have been proved in the flight crew performance, and the meaning a flight crew is by law limited how much hours you can work. And how much hour you can fly. And the pilot on a transatlantic flight or a longer flight, after a certain amount of hours, he has to go in the booth and sleep, and there's another pilot taking over. And this is something what we should keep in mind. What we're doing from the stress, concentration, responsibility is very similar to this. So I think we should organize our structures to this and maybe avoid doing 20 hours operations or 10 hours in the OR without a break, even if sometimes the system demands us to do. Memory will be diminished, attention will be reduced, the mood will be bad, tension arises, then social factors, behaviors come into play, and then the whole thing goes south and is not good. And you can sometimes you notice yourself when you're in OR and you see their stress, you can really see how within a moment of this concentration really goes down, and the whole ship sinks to one side. So this is something very important. Framework and competencies in the teamwork. So a team has only an outcome which is as good as a mixture between the knowledge, the attitude, and the performance. Knowledge is a shared, basically, mental model. You all have to have the same mindset on what you want to achieve. The attitudes are a team orientation and mutual trust, and the performance is measured by adaptability, accuracy, productivity, and efficiency, and safety. All this together, and you need to put your team together and speak with your team regularly to achieve this kind of transition between. What factors are affecting teamwork? Now, first of all, it's the structure. How do you structure a team? Is it quite clear in a way how this team is structured in the way everybody knows to who is responsible for a certain area, or is it not? Is it kind of open? Is this a little bit, everybody does a little bit everything? Is a communication established? Is your staff ready to come to you and say, look, I have a bad feeling with us doing this patient, or I have not a good feeling with this current? Are they open? Are you open enough to the critic of your own team to maybe ask yourself of not doing something or not? Are you exceeding a fair leadership, a just leadership? We're going to speak about this later. So do you do situational monitoring? Can you decide that within the situation, maybe a decision which normally is right is not right now? And is there mutual support between all the members of the team? So it's a multi-team system, and this is very important that we should really, really train this. And you can train this with meetings, you can train this with activities, and a general open structure. Recurrent staff training, the minimal recurrent staff training which I do with my staff, my nurses, and everybody who works is regular CPR training, clinical emergency setting training. You need to know, look, fire in an OR, very, very rare. But when it happens and the people don't even know where the fire extinguisher is, you're in trouble. And we work with oxygen, we work with electrocautery, it can happen. We have alcohol, ignition solutions, so do train this, train emergency setting. Surgical site infection prevention, hand hygiene. People get sloppy over the years how to wash, how to disinfect. Cleaning, sterilization, high-level surface disinfectation, and safe injections. All those things should be treated in recurrent training with your staff, with your nurses, your therapists, with everybody who works in your clinic and is responsible for the outcome of your patient. Because at the end, who's responsible at the end is you, not the patient. You, especially in an ambulatory center like mine, you have to have organizational learning. That means the structure over the years should get better. It should not get worse. So you have to have resources and values and policies. You need to implement them. You have to self-manage the support. You have to give a decision support for the others. You have to have a system design which you delivered, and you need a clinical information system, because if you don't have a clinical information system, you cannot get better because you cannot measure yourself. So you need to measure yourself, and you need to measure your errors. And only by this you can do a productive interaction between an informed, activated patient and family, which is paramount on one side, and a prepared, proactive, and practice team. And then you get good functional and clinical outcomes. Continuous improvement. Some outcomes for high reliability in ambulatory surgery sample. No needless deaths. I repeat it. It sounds maybe horrible to say this, but we cannot afford needless deaths. That's it. No needless pain. This is comfort, but I think quality is measured on this as well. No helplessness on the patient side. Sometimes I have a patient who had great result or whatever, but she's crying because some step in the whole procedure she felt not taken in the arm. She didn't felt, she felt like she's a wheel in a structure, even if the structure runs smoothly. But we have to avoid this feeling. No waiting times and no waste, or minimize waste at the maximum as we can. Continuous improvement works about 3 duties. The duty to avoid causing unjustified risk or harm, the duty to produce a good functional outcome, and the duty to follow a certain procedural rule. And then on the other side, you have to create for your center certain organizational and individual values. These values should be based primarily on safety, secondly on cost, thirdly on effectiveness, equity, and dignity. You can make this list as long as you want, depending on your structure, but these are minimum values which you have to include. Continuous improvement. How can you achieve high reliability in an ambulatory surgery care center? You have to see yourself as a part of an interdisciplinary team, and you have to meet center-defined standard of care. Every center will define the standard of care. I love the blacklist from Jorge. I have a blacklist as well, so you have to define who meets your standards of care and who not, and don't take the people into your structure where you think they just don't meet your standards of care. Nurses and team meet the standards, you make a regular assessment, and you make a regular feedback from the patients and from the team. And how is the best way to do this? You do a qualitative certification. We're ISO certified as a private clinic. It's very rare here in Spain, but these certifications force you to do a feedback, to do assessment, to get this feedback, and to really improve the way how the structure implementation works. Error management. Human beings, me included, you included, we are weak. We suck in error management because it goes against our proper pride and the way that normally nobody likes to make errors. It's not nice. You have to admit it to yourself, to your team. It's not good. So, but it's a way, or we can only detect mistake if we have a non-punitive error reporting. Somebody can say that something is wrong without your, basically how we're used to it, how it was in hierarchy structures, that you hit on his head and he thinks the next time twice if he speaks up. It's a blame-free environment. It may be confidential in some points. Sometimes you have to make the possibility that somebody can tell something in confidentiality because there are behavioral aspects with the rest of the team. You have to have a near-misses reporting, that even if something just went well, that your team, your colleagues, can sit together and say, look, we were just lucky there, and let's dissect why we were lucky, and let's learn from the fact that we were lucky and it didn't go wrong. But not just say, oh, we were lucky, so we don't need to speak about it, nothing happened. That's not wrong. It's so-called a near-miss reporting. We have this in aviation as well. Adverse event reporting is very basic and very important. The single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. And I can absolutely say this, when I was a young resident, we always did get punished for our mistakes. That means the classic university hierarchy is you do something wrong, you either don't go in the OR anymore or whatever, you get punished. What do people? They hide. We all did hide all our errors from our chiefs. This is, you find ingenious ways to cover things up or to make something quickly in behind. That's not the idea. A structure doesn't get better from this. So look in your own structure and see if, not in the main way, but if there's some tendency where you can get better in this way as well, to not punish people for reporting something which is not good. Error management, how you respond to mistakes. You analyze the nature of the mistake, you make an adaptation of processes where it's needed, you give a leadership response. And this leadership response is to either console or to coach or to punish. I go to this later. It's called a just culture. You implement a just culture. What is just culture about? It's about creating an open and fair and just culture which creates a learning culture for everybody, where human errors, adverse events are influenced in the system design, and where basically the manager is organizing this culture in the way that safe system can only be designed based on errors. It can only do based on errors. And we need to manage behavioral choices. What does this mean? Behavioral choices means there are many different kinds of error. There is a human error, which is an inadvertent action, a slip, a lapse, a mistake. You can manage this through changes in process and procedure and training or in design. In this case, if somebody does a human error, you console. You don't punish. You say, it's fine, we'll work it. It will be better next time. I explain you how to make it better. Then there's something we call at-risk behavior. That means somebody does a deliberate choice to make something which is not justified, which is not recognized, which doesn't follow clinical standards, and you have to remove incentives for this. Let's say, if a work is easier because you don't do the check and it becomes longer from them, people tend to do at-risk behavior. You have to create incentives for healthy behavior. That means a behavior which is not risky to go against your clinical standards. And you have to increase situational awareness. This is called coaching. So these things you coach. And then you have a last thing, which is reckless behavior. Reckless behavior you have to punish. And meaning punish remedial action, punitive action. And that's the only way, because reckless is a behavior which you cannot coach or console. It's something which should be in. In the error management for ourselves, as well as a team leader, we should be very aware that you can be confident, and you should be confident. We should be confident. You do mistakes, but you try not to repeat them. But you should not be overconfident saying, I'm too perfect to make any mistake. And effective team leaders, this is very hard to be a team leader. And I'm still working on it. I'm growing into it, and I have a big team now, but I need 10 years to be halfway a decent team leader. You have to organize, to review, to assign. You have to do a lot of work, what you see here. And you have to grow into this role. And I'm going to close with this in my time. The difference between a boss and a leader is very good visible here. And patient safety starts with the difference between being a boss and being a leader. A boss demands, relies on authority, issues ultimatums, says I, uses, takes credit, and places blame. A leader coaches, relies on goodwill, relies on people feeling good in the team, generates enthusiasm for the whole process, that people must be happy working with you. And you have to develop people, not only yourself. Develop your staff, make your staff feeling proud on publications, your juniors, your residents. You have to give credit to them, not only me. So that's very important. And with this I close. I think we're right in time. Thank you, Barcelona. Thank you, ISAPS, for inviting me.